kind of spell it out for you. So if you have a look, this is a nice lady who comes to me with, just 1 second, where she had her first implant 1988 above the muscle. Then they tried to fix it. And then in 2001, the right one was ruptured. And so in 2006, she ended up getting right grade 3 capsular contracture. Another surgery, '07, right grade 3 capsular contracture with displacement. In 2016, she was noted to have a right ruptured implant and left capsular contracture grade 3. So she has had the first set above, the rest of the sets below, multiple capsular contractures, 2 ruptures on the right, 1 rupture on the left, and obviously with all the scarring. So as you will see, so she was a complex case in the sense that she had this skin that was excised. This is the incision, and the distance from the nipple down to the crease is the same, 5.3 centimeters on both. So I did balance it out by cutting most of the skin here and contouring it. And this is the excess skin that she had significantly bottoming out. So this is the implant capsule. As you can see, this was a below the muscle, and if you will see, there is ethibond suture that is noted. This green thick braided suture that's in the proximity of the implant. Ethibond suture, and we'll see plenty of it, ethibond suture. So what I'm going to do now is I'm going to go ahead and cut this, and we will see what is a textured implant. You see how weepy and like it's literally very, very wet, if you will. Very interesting. You see how this is, if I may. Look at all this fluid. And if I go like this, you're going to see it. Very thick and viscous. And we'll do some more of this. You can see right here. Look, none of this spilled into the chest. And that's the whole etiquette of the surgery. So you have to assume that, let's say, it does not appear to be frankly ruptured, but you can see it's so weepy. And let me go ahead and hold this out. So there is fluid around it. Look at that. And extremely, I use the word wet. Not enough fluid to send to cytology. You look at this one right here. None of this spilled, and I'm going to send this tissue off. This starts, it looks like a maggot egg, if you will. So you will see all of this. None of this fluid spilled into the chest. And the whole surgery is done. You can see how thick and viscous this is. Look at this. None of this spilled into the chest. And you never know what you're going to find. Intact implant, as you can see, from 2016. And I'm just going to read this off. $300. I'm going to go ahead and rest it here. And so you can see, look at this. So this is the capsular tissue. You can see how thin this is. Right here, you can see my blue glove. No matter how thin, it is done where none of this fluid spill into the chest. And so you can see, look at this ethibond suture, this green suture running. And if you see, it was rubbing against this implant. And in my practice, as you've seen, I don't want anything foreign, hard. It's like something rubbing against butter, if you will. It's going to only cause problems. So I'm going to go ahead and, this is the capsular tissue. Remember, the pathologist is only going to be able to, you have to send the whole thing. I saw one patient went to another surgeon, they cut a small part out and sent, no, you have to send the whole thing. You have to send the whole thing. There is no exception, especially when you have this even small amount of fluid. I'm going to send this piece along. Now, this is the right chest mass. Because she has had history of 2 ruptures, I cleaned out the whole bottom and on the side. So the surgeon, I saw the op node, cleaned it with copious amounts of irrigation, normal saline and antibiotic irrigation. What it does is it takes this fluid and spreads it out. That ruptured silicone spreads it out, and if you ask me, causes more damage than good. So now all of this tissue at the around in the chest, I removed, cleaned it out, and I'm going to send this out at right chest mass. I don't want to touch the inside, but as you will see, this is all inflamed tissue that I've removed that I saw was not healthy, good. And you can see there is, it does not look good, it does not feel good, it does not palpate good. My sixth sense says it's not good, so it has to go because of the history of 2 previous spillage. And this is the residual capsule above. So as you can see, I did remove all of this. There was part of this muscle that I had to remove because it was very attenuated. It was either I left the capsule behind or I removed some of the muscle, and unfortunately, for a complete thorough removal, she's still got a lot of ample muscle remaining, but this has to be done in the manner as described. Now what I'm going to do here is I'm going to remove my top sterile glove. I have another sterile glove underneath, and we're going to do likewise on the left. So above the muscle residual capsule, you can see I removed this left chest mass right here, and I am going to go ahead and now you will see the ethibond suture again on the inside. You can see how transparent, thin ethibond suture right here, how below the muscle, and I'm going to go ahead and cut this open. Again, the same weepiness, like look how it's crying. The implant is leaching out this badness, and this is this whole gel bleed phenomenon. This is more than what I have seen, and if I pull this out, you'll see very thin capsule, and look, it is very wet. Nothing enough that I need to send off to. Look at that. It's very thick and viscous, right? Imagine I send this off for analysis. It's going to show that gel bleed phenomenon. 250 on the silicone implant intact, textured, and 250. And this is your mentor. So you can see none of this built into the chest. And I'm going to go ahead and take my glove and we're going to assess. Look at the inside. Right? If I go take the inside, look. If I showed you this and I say, what do you think the implant is? You're going to say it's ruptured, and I'm going to say, no, it's intact. And it's that leaching phenomenon, if you will, the gel bleed. And look at the suture again, heavy amounts of ethibond suture. Not a good idea to put in the proximity of what is the implant. And so I'm very happy and content with how the whole surgery went. Very tricky surgery. And I'll tell you, this is my first case. Remember, this surgery is not about speed, it's all about thought process and accuracy. So as you will see, the implants will be returned to the patient. The implants will be returned to the patient. Capsule to be sent to pathology, rule out the BIALCL, CD30 analysis, rule out lymphoma, rule out malignancy, rule out any abnormal pathology. Right and left chest mass separately to be sent to pathology, again to rule out the abnormality pathology, and right and left residual capsule above the muscle to be sent separately. And there you have it. This is Dr. Khan, Executive for Plastic Surgery.